The Shikani speaking valve is a cutting-edge product that can increase the quality of life for your tracheotomy patients. With this unique valve, the patient and clinician have complete control over how airflow is directed into the upper airway. Depending on how you turn the valve, it can either function as a bias open valve or a bias closed valve. If you place the notch in the 12 o'clock position, the valve functions as a bias open valve. In this position, the patient breathes through the tracheostomy tube as if they're not wearing a valve until they go to voice. When they want to voice, the normal exhalation forces that we all use to voice seals the valve and redirects air into the upper airway. Voicing with the valve in the bias open position is completely intuitive, and pediatric patients can easily learn to voice using the valve in this position without any instruction. The bias open position is crucial for patients with unique anatomy or severely compromised respiratory function who cannot tolerate every single breath through the upper airway. It is also an excellent starting position and has been found to decrease anxiety and increase initial acceptance towards wearing a speaking valve for patients of all ages. If you place the notch in the 6 o'clock position, the valve functions as a bias closed valve. In this position, every breath is redirected into the upper airway. This position is excellent for patients who are working toward weaning from their tracheostomy tube or patients who are on a PO diet and wish to increase subglottic pressure for swallowing. Many times, patients initially use the valve in the bias open position and eventually transition to the bias closed position as their respiratory status improves and they feel more comfortable wearing a speaking valve. Due to the flexibility of the Shikani speaking valve, many patients who have never tolerated a speaking valve before can use the Shikani speaking valve. After using the Shikani speaking valve, you'll find that the flexibility and decreased resistance of this valve cannot be matched. For more information about the Shikani speaking valve and other products from the Airway Company, please visit theairwaycompany.com.
Until the recent introduction of the Shikani tracheotomy speaking valve, there have been no significant technological improvements or innovation on the flapper-type speaking valves since these were first introduced in 1985 by Passimir and later by Shiley. The Shikani speaking valve is a novel type of unidirectional speaking valve based on a moving ball inside a valve chamber rather than a flapper membrane that moves in and out with inhalation and exhalation. Multiple studies have shown that the Shikani ball valve design is associated with lower airflow resistance as compared with the flapper valves, and it translates clinically into enhanced patient comfort and tolerance, and significantly superior speech naturalness and olfaction. To better understand the function and the advantages of the Shikani speaking valve, it is important to first preview the normal physiology of breathing and swallowing and the benefits of attaching a speaking valve to a tracheotomy tube. Normally, in the absence of a tracheotomy, air is inhaled and exhaled through the nasal cavity and the oral cavity, allowing speech as airflow goes through the larynx, and smell, filtration, warming, and humidification of air as it goes through the nose. During normal swallowing, the epiglottis folds, the vocal cords close, and breathing stops. Positive tracheal subglottic pressure is generated. The larynx then elevates and moves forward. The folded epiglottis over the larynx protects the airway and directs food and liquid into the esophagus while the patient is swallowing. A tracheotomy is an opening that is surgically created through the neck into the trachea in order to allow the patient direct access to breathing. The most common conditions that require a tracheotomy include prolonged intubation, which is the most common reason for a tracheotomy, airway obstruction, with conditions that include head and neck tumor, infection, trauma, vocal cord paralysis, and others, failure of extubation, respiratory failure, respiratory paralysis, neurologic disorders, with conditions that include stroke or degenerative disorders and others, and pulmonary toilet in order to improve respiratory function. What are the consequences of a tracheotomy? When a tracheotomy is done, the normal physiology of the airway is radically changed, and the patients are clinically affected in multiple ways. As airflow bypasses the larynx, patients lose their ability to speak and communicate, which can cause substantial distress and anguish. In children, this can result in a significant delay in speech development. A tracheotomy can also adversely affect swallowing and cause dysphagia. Because airflow is directed through the tracheotomy tube, air bypasses the nasal cavity with subsequent decreased olfaction, loss of sense of smell, taste, and subsequent loss of appetite. In addition, essential functions of the nose, which include humidification and filtering of inhaled air, are lost, pulmonary secretions increase and become more thickened, and there is an increased risk of lung infections. Because air escapes through the tracheotomy tube, patients lose their ability to generate positive subglottic tracheopulmonary airway pressure, so that they are unable to generate physiologic PEEP, or positive end expiratory pressure. Without PEEP, the alveoli, which are tiny sacs in the lungs that allow exchange of oxygen and carbon dioxide, can collapse. This causes atelectasis, decreased oxygenation, increased and thickened secretions, and subsequent pulmonary infections. Attaching a speaking valve to the tracheotomy tube restores airflow to the upper airway. This allows air to pass through the tracheotomy tube upon inhalation and then get redirected through the larynx and the nasal passage upon exhalation once the valve closes, restoring the normal physiologic function of the upper airway and the nose. If the tracheotomy tube happens to have a cuff, it is important to make sure that the cuff is completely deflated, so that to allow airflow around the tracheotomy tube and into the upper airway. The Shikani speaking valve allows many of the normal physiologic functions of the upper airway to be restored. Patients can hence achieve an improved quality of speech and communication with a louder voice and longer uninterrupted speech. Olfaction and smell, along with taste, which were reduced following a tracheotomy, are significantly improved, hence enhancing appetite and nutrition. Swallowing is also improved with reduced risk of aspiration. The closed respiratory system restores positive subglottic pressure and physiologic PEEP, which facilitates secretion management, reduces infection and lengths of stay, resulting in a significant cost savings to the healthcare system. The traditional speaking valves currently on the market are flapper-type valves, which include those manufactured by Passimir and Shiley. The design of the flapper speaking valves, which has not changed since these were first introduced in 1985, includes a membrane or a diaphragm which flexes upon inhalation and allows air to pass through the tracheotomy tube. Upon exhalation, the airflow is reversed and the membrane closes with no air leak, causing redirection of airflow through the upper airway. These flapper valves are always 100% closed upon exhalation, a feature that is called bias closed, which means that zero air is allowed to go through the speaking valve upon exhalation. The flapper design valves have several shortcomings. The bias closed membrane of the flapper valves often cause a feeling of panic upon first-time introduction of the valve to the tracheotomized patient. This requires the speech-language pathologist to spend significant amount of time coaching and preparing the patient to the first-time introduction of the speaking valve. A certain degree of repetitive breathing effort by the patient is required in order to allow the membrane to flex and open with each inhalation. Since the average person takes about 20,000 to 30,000 breaths per 24 hours, the numerous repetitive efforts required to open the membrane during inhalation can cause a significant challenge to some of the tracheotomized patients, especially the young children, the elderly patient, and the patients with pulmonary compromise who tend to fatigue easy and are hence unable to tolerate flapper valves. One final significant clinical problem noted with these valves is that the flapper membrane tends to degrade over time with repetitive opening and closing, resulting in the uncomfortable honking or fluttering type of noise that is observed with a flapper valve that has been used for several weeks. The Shikani speaking valve is a different type of tracheotomy speaking valve which is manufactured in the United States of America by the Airway Company. The Shikani speaking valve has a polymer cylindrical chamber and a small nylon ball that moves back and forth with inhalation and exhalation rather than the flapper membrane. Because the flapper type speaking valve relies on a membrane that folds in and out, the membrane has to be of a certain size and certain thinness, otherwise it will not fold. Hence, by design, a flapper type valve is always larger than a ball type valve. The front diameter of the Shikani speaking valve is only 1.5 centimeter, 25% smaller than the 2 centimeter of the Passemere flapper valve. The small size of the Shikani ball type speaking valve allows its appearance to be low profile and discreet, a feature which is very appealing to the tracheotomized patient. Another advantage is that, contrary to the flapper membrane, the ball does not degrade over time with repetitive opening and closing. Hence, contrary to flapper valves, the phenomenon of voice honking or fluttering is not a feature that is noted with the Shikani speaking valve. The outside chamber of the Shikani speaking valve has an eccentric or slightly off-center frontal opening that allows air to enter upon inhalation. The inside of the chamber has a cage with strategically positioned ramps at 2.5 degree angle which function as a dynamic guide that directs the ball anteriorly towards the frontal opening of the chamber. The cage also has two vertical bars which act as a stop mechanism, preventing the ball from moving posteriorly towards the trachea. The Shikani speaking valve offers an adaptable and dynamic design two-way mode of use that allows the tracheotomized patient total control of the speaking valve and over when to breathe and when to speak. Based on the patient's needs, the valve can be attached in two different modes. The 12 o'clock or valve up position, whereby the small half-moon shaped notch and the green line are at 12 o'clock or pointing upward, and the 6 o'clock or valve down position, whereby the small half-moon shaped notch and the green line are at 6 o'clock or pointing downward. These modes have special importance on how the valve can be used by the tracheotomized patient. When the patient is standing or sitting normally in a chair, the tracheotomy tube and the speaking valve are typically tilted slightly upward at an angle about plus 20 degrees above a theoretical horizontal line. In this mode, the ball has a tendency to sit posteriorly inside the chamber and away from the frontal opening. This corresponds to a bias open position and provides a widely open airflow passage that allows the patient to breathe through the valve in a routine manner, softly inhaling and exhaling air back and forth without moving the ball, as if there was no valve at all. Contrary to the flapper-type valves, there is no need for any repeated inhalatory effort to open the valve membrane 20,000 to 30,000 times per day, which translates into less effort and significantly superior patient comfort. When the patient wishes to vocalize, a slight ordinary exhalation force, like the one we all have when we normally speak, is all what is needed to cause the ball to move forward and close the frontal opening, hence redirecting air through the larynx. This 12 o'clock mode hence gives the patient complete control of how to use the valve and when to breathe and when to speak. One additional important feature of the bias open 12 o'clock mode is that it allows the speech-language pathologist a much easier and smoother first-time initial introduction of the Shikani speaking valve as compared to the flapper valve, as there is no feeling of panic caused by the bias-closed membrane of the flapper valve. When the valve is placed in the 6 o'clock position or valve down mode, the ball then automatically rolls forward along the 2.5 degree ramp towards the frontal circular opening, closing the valve and redirecting the air into the larynx, hence allowing speech. With a slight inhalation, the patient can still easily roll the ball posteriorly into the chamber and allow air through the tracheotomy tube and the lungs. The 6 o'clock position is best suited for patients who want to speak for an extended period of time or who wish to swallow and eat. Some patients may find that intermediate positions, such as the 3 o'clock or the 9 o'clock positions, are also beneficial as they allow an additional versatility of use of the Shikani speaking valve. With time, many patients learn intuitively how to control the movement of the ball inside the chamber of the Shikani speaking valve by changing the angle of their body from plus 20 degrees above the horizontal, which is a bias open position, to 0 degree, to minus 15 degree from the horizontal, which is a bias closed position. The patient hence learn instinctively, almost like riding a Segway, how to move the ball inside the chamber by moving their body, optimizing when to speak and when to breathe. A multi-institutional study was done to evaluate the airflow characteristics of the Shikani speaking valve in different angle orientations and compare them to the Paciente valve, which is the most commonly used flapper valve on the market. The study was done in collaboration with researchers from the National Institute of Health and the University of South Florida, and it was published in the American Journal of Speech and Language Pathology, the leading U.S. peer-reviewed journal in the field of speech and language in the United States. Using a pneumotachometer, which acts as an artificial lung machine, the airflow and resistant characteristics of the Shikani speaking valve were measured at different flow amplitude and the different degrees orientations from the horizontal, both in the 6 o'clock and 12 o'clock configurations, and these were compared to the airflow and resistance characteristics of the Paciente valve. When the Shikani speaking valve was placed straight or at 0 degree from the horizontal, the valve demonstrated significantly lower airflow characteristics compared to the competitive Paciente flapper valve across all airflow amplitudes in the 6 o'clock and 12 o'clock configurations, in normal breathing and light daytime activities where the tracheotomized patients typically wear a speaking valve, which is between 0.1 and 0.3 liters per second. The statistical significance of the superiority of the Shikani speaking valve was confirmed across the board using an analysis of variance, or ANOVA. When the Shikani speaking valve was placed in the plus 20 degree position, which corresponds to the patient in the sitting or standing position, The valve also demonstrated significantly lower airflow resistance as compared to the competitive flapper valve across all airflow amplitude in the 6 o'clock and 12 o'clock configurations, in normal breathing and light daytime activities where the tracheotomized patient typically wear a speaking valve, which is between 0.1 and 0.3 liters per second. The statistical significance of the superiority of the Shikani speaking valve was also confirmed using an analysis of variance, or ANOVA. When the Shikani speaking valve was placed in the minus 15 degree position, which corresponds to the patient bending forward, the valve also demonstrated significantly lower airway resistance compared to the competitive Passimir flapper valve across all airflow amplitude in the 12 o'clock configuration, in normal breathing and light daytime activities where the tracheotomized patient typically wear a speaking valve, which is between 0.1 and 0.3 liters per second. In the 6 o'clock configuration, the airflow resistance of the ball valve approached that of the flapper valve at lower airflow amplitude, but then trended to decrease airflow resistance at higher airflow amplitude. The statistical significance of the superiority of the Shikani speaking valve was confirmed across the board using an analysis of variance, or ANOVA. These lower airflow resistant characteristics of the Shikani speaking valve translate clinically into better patient acceptance, enhanced comfort, and enhanced ease of breathing, and an increase in wind power. This is particularly noticeable in the pediatric patient and in the elderly patient with borderline pulmonary compromise.
Okay, wait. James is supposed to be speaking. Make James speak.
James!
Okay. Yell some words, Jamie.
Yes.
Yell some words, Jamie.
Yeah.
Okay, put your speaker valve on your trachea and I'll get you out your plasma card.
Okay.
Okay, what kind of speaker valve is it, Jamie? Is it a Shikani?
Shikani.
Say Shikani speaker valve.
Shikani speaker valve.
Say, Mom, may I please have my plasma card?
Mom, I please have my plasma card.
You may have your plasma card. Okay, sing some songs while I'm getting it for you. Okay, so this is to demonstrate the wind power while he's wearing it. Because this is pretty good exercise right here. So he's off. He's going on about his business. The nurse is just kind of sitting around, being a nurse, monitoring things. Jamie!
Hi, Joseph. How are you?
Fine, thank you.
Joseph is 80-year-old. He has a cancer of the larynx and he has vocal cord paralysis after radiation therapy. This was done all the way in 2006. And he's been wearing the Passimir, but he's having a hard time with it. What's the difficulty with this pink valve? Do you have any problem with it?
When I breathe outward,
It's hard to breathe?
hard to
Okay.
breathe out. But this one was easy.
Okay, so you take it out from time to time to take a break. Let's take the pink valve out a little bit. And let's put this ball valve on and put it on. How do you feel? Is it easier to breathe?
Breathing out much easier.
Much easier. This is the first time you use it, right? You
Yes.
just got it for the first
First
time.
time I knew that they one.
And you like it?
I like it. But my breathing and my talking is a lot better
Lot better.
than before.
More free breathing?
Yeah, my voice is not, I'm not pitched as high.
Okay.
And my voice is more of a normal tone.
Okay. Well, we'll let you keep this Shikani speaking valve, the ball valve, and see how it goes over the next few days.
I
and
thank you
hopefully-
very much.
Okay.
A controlled prospective IRB approved clinical study was done comparing the Shikani speaking valve to the pacimente flapper valve and the shyly flapper valve. The study was published in the International Forum of Allergy and Rhinology, the leading peer-reviewed journal in the field of rhinology in the United States. Loss of smell or loss of olfaction is a well-recognized phenomenon in patients who have had their nasal airflow diverted through a tracheotomy. By redirecting airflow to the nasal cavity, the Shikani speaking valve resulted in a superior and highly significant improvement in olfaction and restoration of the loss of smell, as compared to the shyly and the pacimente valves. The statistically significant improvement in the olfaction score in favor of the Shikani speaking valve, which is shown in red, was confirmed using an analysis of variance, or ANOVA. The data also demonstrated that the Shikani speaking valve was associated with a superior and highly significant improvement in the speech naturalness scale as compared to the pacimente and the shyly speaking valve. This is a visual analog scale from 1 to 9 that measures voice, pitch, and how natural the speech sounds. The statistically significant improvement in speech naturalness in favor of the Shikani speaking valve, which is shown in red, was confirmed using an analysis of variance, or ANOVA. The Shikani speaking valve also proved to be superior to the pacimente and shyly valves in the general speech parameters, including maximum phonation, S-Z ratio, jitter, noise, and turbulence. But the differences for these did not reach statistical significance. There was no difference among the valves in oxygen saturation levels. Because of its ease of breathing and its smaller size and lower profile, 80% of the tracheotomized patients in this study preferred the Shikani speaking valve over the pacimente and shyly speaking valves. Countless patients find the Shikani speaking valve changes their life as it is much more comfortable and it allows them to breathe freely as compared to the flapper valves.
In 2007, I was diagnosed with bilateral vocal cord damage, and I was trached, and I was given another speaking valve. It was very difficult for me to breathe. It was very tiring, and it took a lot of energy. I went back to work and realized that I needed something that would benefit me to breathe easier. And I was sitting in a meeting one day, and I was having a hard time breathing, and someone suggested I put on this Shikani speaking valve. And I put it on, and I've never taken it off since then. The Shikani speaking valve changed my life dramatically because I work as a social worker, and I do a lot of talking, and I work in a hospital with a lot of different people. And when I used the other speaking valve, it was very tiring. And at that point, I thought, I can't work because I was so tired, and I couldn't talk a lot, and I couldn't breathe a lot. So I got the Shikani speaking valve, and it completely changed my life because I was able to talk and I was able to breathe freely. And it's very refreshing to be able to breathe freely with no obstruction.